بسم الله الرحمن الرحيم. في عالم يتسارع فيه التطور العلمي ويزداد فيه التنافس المهني، كان لابد من منصة عربية تجمعنا على هدف واحد: العلم والتميز. نقدم لكم ستايل أربيانو كونفرنس، أكبر مؤتمر عربي أونلاين في طب الأسنان، يجمع أكثر من 100 محاضر من مختلف أنحاء العالم العربي في جميع تخصصات طب الأسنان دون استثناء. مهمتنا واضحة: أن نوحد الخبرات العربية ونقدم محتوى علمي قويا حديثا قائما على أحدث الدراسات والتقنيات ليصل إلى كل طالب وطالبة وكل خريج حديث وكل طبيب يسعى للتطور والارتقاء بمستواه المهني. هذا المؤتمر ليس مجرد محاضرات، بل هو رؤية جديدة للعلم ومنصة تجمع الطموح بالخبرة وتفتح أبواب المستقبل أمام كل من يسعى للتميز. ستايل أربيانو كونفرنس، حيث يلتقي العلم العربي ليصنع مستقبل طب الأسنان.
عدني من عندك تاني. السلام عليكم يا دكاترة، يا رب تكونوا بخير وكل سنة وحضراتكم طيبين ورمضان مبارك عليكم جميعا. النهاردة رجعنا لكم بمحاضرة جديدة في تخصص الأورثودونتكس مع دكتورة إيناس بوديلي داوود. أهلا بحضرتك دكتور إيناس.
شكرا على الاستضافة، وأنا فرحانة برشا اللي نكون معكم اليوم.
شرف لينا يا دكتور إن حضرتك معانا النهاردة، وهنستأذن حضرتك هناخد دقيقة بس من وقت المحاضرة، هنعمل سحب
أوكي، مش مشكلة، تفضل.
وإن شاء الله محتاجين في آخر المحاضرة من حضرتك سؤالين
إن شاء الله
من خلال المحاضرة، وفي 2 هيكسبوا معانا إن شاء الله.
إن شاء الله، بالتوفيق للجميع.
أول فائز معانا، طبعا إحنا بنعمل السحب إن بابليك علشان الشفافية. أول فائز معانا إن شاء الله دكتورة منى شرك. ألف مبروك يا دكتور منى. الفائز رقم 2 معانا دكتور محمد أحمد غنية. ألف مبروك يا دكتور محمد، أول مرة يكسب معانا تقريبا.
مبروك.
آخر حد هيفوز معانا من خلال السحب دكتور مياسير. ألف مبروك يا دكتور. كده احنا أخدنا 3 معانا، وإن شاء الله دكاترة في آخر المحاضرة في 2 هيفوزوا معانا. هنعمل شير سكرين للمحاضرة دلوقتي يا دكتور. المحاضرة ظاهرة تمام كده؟
أنا ظاهرة عندي، وأنتي دكتور؟
تمام. اتفضل يا دكتور. أنا مع حضرتك في الباك جراوند، لو في أي حاجة في الصوت أو في أي حاجة في الأسئلة من الدكاترة أنا ببلغ حضرتك إن شاء الله.
Inshallah. Thank you very much, and thank you for joining me to discuss the clinical protocols for multidisciplinary coordination in orthodontic treatment. للناس اللي ما تعرفنيش، أنا دكتورة إيناس بوديلي حرم داود. I'm an orthodontist in my private practice, and أنا خريجة كلية طب الأسنان بالمنستير، هي الوحيدة في تونس كلية طب الأسنان بالمنستير, and postgraduated from the University of Toulouse, France as an orthodontist. متحصلة أيضاً على diploma in anesthetic and orthodontics with aligners from the University of Monastir, diploma in Damon system from Madrid, and I'm an international speaker. مرحبا بكم الناس الكل. So before to start, the collaborative dentistry is classified into 3 categories: the unidisciplinary, multidisciplinary, and interdisciplinary. And during the first part of my presentation, we will discuss each category based on clinical cases. Let's start with the first category, the unidisciplinary, and where each clinician worked independently without regard to planning and coordinating treatment. The most common example is the peg-shaped lateral, and this is an underdeveloped permanent teeth resulting in a cone-shaped appearance and reduced size. So we have 2 options. Either we restore its dimensions before orthodontic treatments or after. So it's better to optimize and correct the position of the lateral if it is possible to bend the bracket to it. And this patient presented a B protrusion, and according to her profile, I decided not to extract. And as you can see also, she presented the peg-shaped lateral incisor, but it was difficult in this case to bend the bracket onto the tooth. So I referred the patient for restoration before starting the treatment. However, it was possible to bend the bracket in this case, so I took the opportunity to correct the typing of the lateral. As you can see, the typing is the inclination of the teeth. Another example, the altered passive eruption. So what is the altered passive eruption? It is a clinical situation produced by excessive gum overlapping the enamel limits, resulting in a short clinical crown appearance that gives the sensation of hidden teeth. The term itself suggests the causal mechanism, and it is a failure in the passive phase of dental eruption. So to understand the two phases of eruption, I want to show you a video that I found on YouTube. And so we have two phases of eruption, the active and the passive eruption. The active eruption is the movement of the tooth from the developmental site to its functional position. And in passive eruption, an apical migration shift of the dentogingival junction occurs. So what is the altered passive eruption? It is defined as a defect in this phase resulting in an excessive gingival display, or what we call also gummy smile, and short square-looking clinical crown. I can't change. I think I have a problem with this slide. Okay, and this is the same situation of my patient whom I referred to my colleague Periu to perform a gingivectomy so I could bend more easily. And the multidisciplinary dentistry is done by multiple clinicians, and this patient was referred by a colleague implantologist to intrude the 6 upright in order to be able to place an implant replacing the 46. And it was possible without taking the entire arch, and thanks to 2 mini screws, vestibular and palatal, and the intrusion was carried out with a cone, and this is the final result. The periodontist was able to place easily the implants, replacing 46 and 47. Ideally, collaborative dentistry ought to be delivered in an interdisciplinary fashion, where treatment is developed through collaboration of multiple clinicians, leaning on the expertise of the team. And this is, and the British Dental Journal published an excellent article to describe the principle of interdisciplinary, orthodontic, and restorative treatment. And the authors was inspired by Ray Dalio's book to develop 5 principles. 1, develop an interdisciplinary treatment plan with the clinicians and patients involved in the process. Also integrate aesthetic treatment needs with functional occlusion goals. Create a realistic vision by simulating the treatment outcome. Formulate a treatment plan with sequential milestones, and very important to communicate and adapt during the treatment delivery process. And remember, we are a team, and that means together everyone achieves more. Let's start with the first relationship, the ortho-endo interrelationship, and endodontists have a major role to play in the interdisciplinary treatment with the combination of orthodontists. You know, the teeth movement largely change the periapical environment of the teeth, and they may be chance of the tooth to lose its vitality or reserve due to orthodontics force. And this is a good article, and Siegel and collaborator stressed that the need for prolonged treatment involving significant degrees of dental movement is a strong risk factor for severe resorption. Thus, the long duration of treatment, the retraction mechanics employed, and the prolonged use of intermaxillary elastic bands may have contribute to the severe root resorption. And that's what happened to my patient, who present a severe crowd in the upper. His main concern were aesthetic, of course, and the treatment was carried out with extraction regarding to his profile and the importance of the crowding. It was a difficult treatment, but at the end, I saw a change in the color of the 12. Effectively, the 12 couldn't withstand the forces that were used during the treatment and lost its vitality. So I referred him to my colleague endodontist. Another case with good collaboration between orthodonts and other disciplines, and this is a complex case because it involved anomalies of 3 dimensions: the sagittal, the transversal, and the vertical. He presented a severe upper crowding and the absence of the first upper molar and the first lower left molar, but above all, a marked alveolar compensation. The treatment was revised in collaboration with the dentist after referral for endodontic treatment of the 36. But the tooth had furcation damage and presented a cyst. Her dentist would decide to extract it, and I find myself with the absence of the 6 upper and the 6 lower, and that changed all my planning treatment. The cephalometrics confirmed with concordant values, a prognatic mandibula, and a dolichocephalic patterns, but above of all, a marked compensation. So I don't know how would you treat this patient, surgical or not surgical. I decided to treat him with orthodontics only. So this is how I treat him. I started with the Hyrex to increase the transversal. I usually push the limits of Hyrex. A posterior turbo for disocclusion. Brackets are placed with bypass 2 and 3, a coil between 4 and 1 with upper interior protrusion permitted that help to correct the crossbite and find some millimeters to place the 3 in addition to the space of 6. And the 8 evolves easily when the 7 mesialize later. In the lower abacus shaft, it is a screw, was placed to retract in mass, and the 7 mesialize and the 8 evolves without problems. Here is the final results: the correction of the occlusion, the correction of the crossbite, and of course the correction of the alveolar compensation. And it took me 34 months to get this result and let you appreciate the end of the treatment. Often orthodontists can be a considerable assistant in prosthodontic treatment. And the most common example is the agenesis of lateral. And so we have 2 options. Either we open or we close the space. And in this case, for example, the patient presented a clinical absence of the 22 and the 2 canine, and X-rays confirmed the impaction of canines and agenesis of 22, and also clinical. You can note and see the presence of a peg-shaped lateral on the 12. In coordination with the dentist, the solution was to close space I start the orthodontic treatment to prepare the arch. Then the surgeon performs a surgical exposure and the traction continues. And here the canine starts to erupt. And here is the final result. I referred her to her dentist to restore the size of the lateral incisor, but she decided to keep the natural 23 without coronoplasties, and I respected, of course, her decision. But it was different with his patient, and in agreement with her dentist, we decided to open the space because of the significant bilateral space, as you can see. And here is the final prosthetic result after placement of a banded Maryland bridge, replacing 12 and 22. Another case, and this patient was addressed by a colleague to fix the anterior bite to be able to restore the 11, because it was impossible for her to restore it. I begin with the lower to retract the anterior block, then the upper to open, by the way, the space for the 11. And here is the final result. And the prosto well restored the central, very, very good result at the end. Move on now to talk about the ortho-perio relationship. And what is the main objective of periodontal therapy is to restore and maintain the health and integrity of the attachment apparatus of the teeth. And this is my another patient. She's in class 1 relationship, a strong overbite with a severe crowding in the lower. His periodontal condition was concerning, so I first referred her to a periodontist who performed an open flap debridement, followed by a periodontal maintenance phase before beginning orthodontic treatment. The correction was carried out with 2 mini screws. As you can see, I placed between 5 and 6, and by this way, I will have 2 compounds, one horizontal to distalize and correct the class 2 created with our appliance, and one vertical to correct the supraocclusion. I always place, in these cases, anterior bite to prevent occlusion plane rotation. This is the end of the treatment, and I let you appreciate the change of her smile. Maybe gingivectomy, maybe she needs gingivectomy, but I like this natural look. Another case showing the collaboration with periodontists, and this patient, class 2-2, with a very strong deep bite. And the treatment, the correction of the deep bite was different this time. And the correction was carried out with 2 interior screws between 2 and 3. And the intrusion was possible with the chain, as you can see. But the intrusion of the interior block has reached its limits, and a gingivectomy is required now to improve the final results. And here is the patient at the final result after gingivectomy, and I let you appreciate the transformation of her smile before and after the orthodontic treatment in collaboration of the periodontists. Move on now to talk about the relationship between ortho and surgery. The interdisciplinary relation between the orthodontic and oral surgery is an important part of the orthodontic treatment planning, and it mainly involves impacted teeth. For a long time, it was believed that with some teeth caused late crowding of the lower incisors after orthodontic treatment, but studies have shown that third molar do not play a major role in the relapse of mandibular crowding, and the late crowding may also occur in patients who do not have wisdom teeth. And what is the effect of orthodontics on the eruption? Orthodontic extraction, often premolars, may increase the space for third molars, and this may improve their chance of eruption, although this is not guaranteed. The outcomes mainly depends on factors such as the mandibular growth, the angulation of the wisdom tooth, and the retromolar space. And in my opinion, these are the principles indication for wisdom tooth extraction. For example, for cases with distalization in spite of extraction of premolar, pathological impaction, recurrent periocoronitis, caries, a resorption, a failure of eruption. These are the main the principles indication of extraction. Now, the collaboration with the surgeon always involves the impacted canine and incisors. Usually we talk about impacted canine. Today I will show you a case with an impacted incisor. And the patient Layla, 20 years old, her main concern was the delay of the centers, and the CBCT confirmed the presence of 2 impacted upper centers ruled out by odontoma, like we can see on X-ray. And the aim of the treatment was to separate centers from laterals. So here's how we treat her. So first we began as follows. A flap was moved, extraction of odontomas, and mini screws was placed with chain, and activate the activation of the chain to mesialize the 2 centers. Then the brackets was placed to maintain or to open the space for the centers. As you can see here by transparency, we can see the 11. Another flap was moved to activate the chain, and then a more vertical traction, and here are the 2 centers, and let me show you the final result. The relationship between ortho and pedo, so early detection of malocclusion, and it's very important to see the pedodontist, because that ensure good oral hygiene and prevent care. Decisions regarding selective extraction of primary teeth to guide the eruption, and the preservation of primary teeth when they are needed to maintain arch length. Also, for space management, placement of space maintainers after premature loss of primary teeth, prevention of space loss that may lead to crowding or impaction, interception treatment, early orthodontic intervention to correct developing problems such as crossbite or severe crowding, manage of oral habits, thumb sucking, tongue thrust. And before to finish, I will finish with this last case. This patient was referred by my colleague, pedodontologist. The girl and her parents was worried about her appearance. She's in class 1 molar, but a severe anterior crossbite, as you can see. Here is the radiography profile, and the cephalometric measurement agree with a class 3 skeleton with a maxilla regrugnatic maxilla. The patient was not yet absent, so I wanted to push the limits of Delaire. In coordination with my colleague periodontist, we started with the Delaire mask or facial mask. And here is the result of the end, after the end of the first phase or the orthopedic treatment. As you can see on cephalometric, a very good simulation of the maxillary growth, and patient is now ready for braces to achieve the treatment goals. And here is the patient at the end of the treatment. I was hurried to remove braces, unfortunately, because they were moving to another country, but everybody was happy with the results. So, to improve patients' care and minimize exposure to liability in interdisciplinary care, the following risk management strategies can be followed and modified as needed. Remember, communication is the key. We have to refer patients in a timely manner to other disciplines' care. Abnormal clinical or radiographic finding detected after acquisition of the diagnostic records should trigger an appropriate referral. It is a mistake to wait and see if signs and symptoms actually result in the patient's injury. Very important also, it is best to avoid verbally prescription. It is beneficial to print relevant radiographies, include them with a referral letter, and advise patient to take both with them to the referred doctor. Follow up with the referrals. It is a mistake or an error to refer and forget, especially in the patient requires immediate attention by another doctor. Assume the role of treatment facilitator. For example, ask the dentist if he wants to provide periodontal and surgical care for the patient, or if he prefers to refer to a specialist. If an interdisciplinary treatment is planned by a colleague, such as a restorative dentist or a oral surgeon, request the treatment plan in writing, especially in complex and surgical cases. And also inform patients of additional costs due to the intervention of one or more colleagues. It's very important also to inform the patient's dentist about non-cooperation. Also ensure that adults present with active or a history of past periodontal disease are receiving maintenance, and inform patients that existing dental work may need to be redone after orthodontic treatment. And very important also, avoid faulting other doctors, and a good doctor will recognize their own mistakes anyway. I want to thank you for your attention. إن شاء الله تكون معلومات فادتكم. And this is, if you want to reach me, these are my 2 social media accounts and my address mail. Thank you.
شكرا دكتور إيناس، يعني كانت محاضرة بسيطة وخفيفة، يعني احنا يمكن استل معانا نص ساعة لو في حد من الدكاترة عنده أسئلة، وكنا بصراحة محتاجين من حضرتك سؤالين من خلال المحاضرة، وإن شاء الله معانا 2 يكسبوا بإذن الله.
يعني السؤال الأول, which treatment should come first in a multidisciplinary case, orthodontic treatment or restorative treatment?
And why ولا هو بس زي MCQ فقط؟
Which treatment should come first in a multidisciplinary, orthodontic treatment or restorative treatment? Which one? The ortho or the restorative? And the second question, what is the most important factor for a successful coordination in dental treatment?
طبعا الكل جاوب السؤال الأول restorative، بس أول إجابة دكتور عبد الله. طبعا الإجابة ظاهرة على الشاشة يا دكتور.
Restorative. It depends of the case, because in my opinion, the most important factor of successful, for example, like I showed for when you, for this patient, for example, I want to return. Can I share my screen, please?
Yes, we see it already.
Okay. For this case, for example, it was impossible to start with the restoration because the dentist needed to correct the bite, the anterior bite. So that's why I retract the incisor in the lower, and then the dentist was able to correct and restore the 11. But yes, in other cases, yes, restoration must be done before, mainly for cases like shaped lateral incisor, like I showed you. It is very important to correct and restore the inclination, the typing, or the rotation of the teeth before to start the orthodontics treatment.
Yes. So we can choose a winner with us, or we can try the question another.
No, it's a good answer.
هناخد اللي قال ريستوراتيف ان شاء الله يعني.
اوكي يلا. ومبروك علي.
دكتور عبد الله اول حد جاوب. طبعا هو السؤال سهل ومباشر MCQ يعني. فالسؤال الثاني يا دكتور ممكن حضرتك تقولي تاني عشان الدكاتره.
Yes. So in your opinion, it's very personal. It's not يعني هو سؤال كل شخص وكيف يشوف what is the most important factor for a successful multidisciplinary dental treatment? وأنا بعد أعطيكم يعني my opinion.
خلاص احنا اكتر اجابه هتكون قريبه من your opinion هو ده اللي هيفوز معنا اكيد. دكتوره هبه بتقول good diagnosis.
Yes.
في دكتور عبد الله بيقول كوب اوف ذا بايريتس. انا بصراحه جديد عليا الاجابه دي بس مش.
Group of parties, what does it mean? Cooperation.
طبعا في
cooperation of parties maybe cooperation of
هو
patient.
عدل الكومنت تاني كتب cooperation of patient. في دكتورة ابتسام بتقول good diagnosis. دكتور
ياسين communication.
يس حضرتك قلت الكوميونيكيشن.
This is my opinion.
حضرتك قلتها في المحاضرة اوريدي يعني قلتها خلال المحاضرة.
Yes, this is the most important communication between patients and doctors, not only between doctors of different disciplines. يعني إذا فهمتني يا دكتور ممدوح.
لا أنا فهمت حضرتك. لا أنا فهمت حضرتك. ويعني أنا حاليا أصلا مركب أورثودونتكس تريتمنت وايرز بريسز أند وايرز. كنت عامل من سنتين أو 3 كمان. من سنة 23 عامل الألاينر بس أنا ما كنتش ملتزم. فحصل ريلابس 4 مرات. بعد ما بوصل الألاينر رقم 8 أرجع لرقم 3 أو 4. وده بسبب إن الألاينر كان بيضيع مني وأرجع أعمل واحد والمعمل كان بيتأخر فبيحصل ريلابس. دلوقتي مركب اللي هو الواير والبريسز وستيل برضو في صعوبة في الكوميونيكيشن بينه وبين الدكتور. فالموضوع صعب جدا. يمكن ده تاني واير رقم 2 وبقالي 8 شهور مركبه لسه ما غيرتوش بقالي 8 شهور.
You're not a good person.
الكوميونيكيشن اهم من كل حاجه.
communication يا ممدوح.
طبعا علشان انا مضغوط في الشغل العياده
لكن هي مره في الشهر يا ممدوح يعني مش صعب.
يعني ده كان الكونسيبت بتاعي. يعني انا قلت له يا دكتور احنا نركب بريسز وواير وكده كده هي مره في الشهر.
مره في الشهر.
أنا يعني بين الواير الاولاني والتاني عدى 6 شهور. يعني بعد 6 شهور غيرت الاولاني وركبت التاني.
يعني انت ممدوح ما عندكش يوم بس في الشهر ما عندكش؟
لا هو اكيد في وقت كل يوم كمان بس الواحد بينسى بيتضغط فبينسى تماما.
شوف ممدوح very important I talked about resorption because of the prolonged treatment. لازم تفكر فيها لانه اذا التريتمنت يطول ومن بعد الأورثودونتس يستعمل فورسز يعني انت تغير له اتجاهه. فهمتني؟ يعني حتى البلينز يتغير. لازم تمشي تشوف طبيبك. لازم تمشي تشوف.
كذا حد قال لي خوفني الموضوع البون يحصل ريزوربشن للاسنان. فطبعا انا كنت باخد وقت ان انا اروح للدكتور في محافظه تانية. دلوقتي انا فاتح عيادتي الخاصه وخلي الدكتور هو اللي يجي لي العياده بقى،
هاي
يعني
الحمد
الامور
لله، المفيد يجيك.
يعني هو اللي هيجي لي انا
المفيد
خلاص.
تشوفه. غيرت الثيرد وان تو.
بالظبط بقى، هو الالتزام واقف عليه هو مش عليا انا، فالحمد لله انا
هاي
كده كده
الحمد
موجود.
لله.
بنشكر حضرتك
في
دكتور
أسئلة
ايناس.
عايزين تسألوني، إذا حابين تسألوني أسئلة مرحبا بكم.
احنا طبعا يا جماعه لسه معانا وقت، فلو حد عنده اي سؤال، هم الدكاتره ستيل بتجاوب، يعني دكتوره سعاد ما شاء الله يعني كاتبه اجابه نموذجيه. بس good diagnosis communication between doctor and patient and other specialty.
Yeah, very
يعني
good answer, yes.
بس احنا طبعا هناخد اول اجابه دكتور مسعودي ياسين. الف مبروك يا دكتور مسعودي، انت اللي
ألف
كسبت
مبروك.
معانا. كده احنا اخدنا 2 فازوا معانا، وان شاء الله يعني تزورونا في باقي المحاضرات يعني. ولو في حد عنده اي سؤال خلال المحاضره ممكن يبعته دلوقتي في الكومنتس، او ممكن بعد المحاضره احنا بننزل لينك الحضور ولينك ريفيو عن المحاضره. لو حد عنده اي سؤال هنبعته لدكتور ايناس، وهنمنشن برضو في الكابشن بتاع المحاضره لدكتور ايناس برضو، لو حد عنده اي سؤال يقدر يتواصل معانا ان شاء الله. بنشكر حضرتك مره ثانيه يا دكتور ايناس. هو ستيل ما فيش اسئله بصراحه، يعني كل الدكاتره
إن
يعني
شاء الله تكون كنت مفهومة وأضفت معلومات. بارك الله فيكم. كنت فرحانة برشا اللي كنت معاكم.
الشرف لينا يعني، وان شاء الله
عندكم
تتكرر يعني بمحاضره، يعني المره الجايه ان شاء الله عايزين حاجه بس تكون ادفانسد في الاورسو. يمكن معانا 2 أو 3 اخصائيين اورسو بيحضروا، فدايما كانوا بيسالوا على محاضرات الاورسو، فيعني ان شاء الله يا دكتور نرتب برضو حاجه تانية مع بعض قريب باذن الله.
إن شاء الله. ونتمنى لكم عيد سعيد. يعني بعد 10 أيام ممكن، ولا 11 يوم العيد. إن شاء الله عامكم مبروك، وكل سنة وأنتم طيبين.
دكتور عبد الله وحضرتك طيبه وخير يا دكتور. دكتور عبد الله كان بيسال بيقول ممكن شرح مبسط عن التيلوب.
تيلوب. I talked about تيلوب.
ما
the,
اعرفش دي.
the banding wire. دكتور عبد الله.
هو هيوضح دلوقتي بس هو كاتب نبغى شرح عن التيلوب اونلي، مش موضح ايه بالظبط. في هنا كومنت بالفرنش يا دكتور، I think ان حضرتك انت اللي
J'ai
هتقرا.
assisté à votre formation en Algérie. هي يعني بتسألني مش تسألني، هي تعلمني إذا كان فما formation in Algeria في الجزائر، لكن أنا ما عنديش علم، ما عنديش محاضرات في معناها مستقبل في الجزائر، لكن إن شاء الله إن شاء الله.
تمام. يس دكتور عبد الله بيقول لحضرتك يس على اللي هو التيلوب، بس برضه ما وضحش حاجة. ممكن
هو أنا فهمته، لكن أنا ما حكيتش عليه في المحاضرة نتاعي. This is a banding in the wire. يعني نعملوا refinements at the end of the treatment. For example, if we have rotation ولا to correct the type of يعني ممكن دكتور عبد الله ممكن أشرح لك، لأنه كبير برشا المجال هذا. You can reach me. This is my 2 social media or my address mail. Write me an email and I will ask you answer.
دكتورة هبة طبعا بتقول احنا عايزين محاضرة عن اللغة الفرنسية عموما. قريب يعني.
أنا حكيت شوي فرنسي. اختفت كلمات.
على فكرة يا جماعة المغربي بالنسبة لكم هيكون أصعب من الفرنسي، يعني الدكتورة لو قالت
أنا تونسي مش مغربي.
تونسي سوري، بالتونسي هيكون أصعب من الفرنسي بالنسبة لكم.
أصعب. هو عربي يا محمود يا ممدوح. احنا
I
بنتكلم عربي.
I think إن هم درسوا شوية فرنسي، لكن تونسي ممكن بعض المصطلحات تبقى بعيدة خالص عنهم لأول مرة
لأنه احنا نحكي تونسي فرنسي sometimes، يعني تصعب.
الدراسة يا دكتور عند حضراتكم في الماجستير بالفرنسي بس صح؟
Yes. French, yes.
يعني مش انجليزي، يعني الانجليزي ده اجتهاد من حضرتك مثلا؟
في محاضرات في يعني الاقسام الجدد فيهم محاضرات بالانجلش، لكن لما انا كنت بدرس only in French.
تمام دكتور ايناس، خلاص كده نكون وصلنا لنهايه المحاضره، ويعني بنشكر حضرتك على المحاضره الخفيفه دي، وكل سنه
كان
وحضرتك
لي
طيبه.
الشرف. شكرا.
وجزاك الله كل خير عنا وعن كل حضور.
امين يا رب.
حضرتك.
الى اللقاء. سلامه.